Assalamu alaikum. Let's dive into hepatorenal syndrome, a must know topic for USMLA. Okay, what is hepatorenal syndrome? What is its pathophysiology? Hepatorenal syndrome is a life threatening complication of advanced cirrhosis characterized by rapidly progressive kidney function. In hepatorenal syndrome, it involves hormonally mediated renal vasoconstriction include by induced by sorry so it involves hormonally mediated renal vasoconstriction induced by portal hypertension and splanchnic vasodilatation. This splanchnic vasodilatation this splanchnic vasodilatation due to excess release of vasodilator like nitric oxide, it causing renal hyperperfusion, and RAS is activated, which overwhelms the renal vasoconstriction and thus causing the AKI. So this hormonal cascade actually contributes to low blood pressure with activation of the RAS, leading to overwhelming renal vasoconstriction. And the precipitancy is a GI bleed infection like spontaneous bacterial peritonitis. Risk factor is advanced cirrhosis with portal hypertension, acute liver failure, severe alcoholic hepatitis. So hepatorenal syndrome risk factors are advanced cirrhosis with portal hypertension, acute liver failure, and severe alcoholic hepatitis. Okay, how we can diagnose? Diagnosis is bland urine analysis, very low urine sodium, bland urine analysis, very low urine sodium, exclusion of other causes of AKI, no improvement with trial of volume expansion, and treatment is albumin plus blanchnic vasoconstrictors like terlipressin, norepinephrine, or midodrine plus octreotide. And liver transplantation is the curative. Okay, we know that hepatorenal syndrome are of mainly two types. It can be classified as type 1 hepatorenal syndrome and type 2 hepatorenal syndrome. HRS AKI more severe type, type 1 more severe type. It is characterized by doubling of the serum creatinine. So type 1 HRS hepatorenal syndrome means doubling of HRS, doubling of serum creatinine less than 2 weeks, and type 2 hepatorenal syndrome, which is less severe, are typically associated with diuretic resistant ascites. So how we can evaluate? A very brief chart for evaluating hepatorenal syndrome. So if a patient comes with AKI, like evaluation of AKI in patients with advanced liver disease. So first, look at this patient. A 62-year-old man comes to the emergency department. Why? Increasing abdominal distension, discomfort. Okay, decreased urinary output. He has cirrhosis due to alcohol use, taking furosemide and spironolactone. He is on diuretics, but there is not that. Even if he is on diuretics, the abdomen is distended, non-tender with positive shifting of the dullness. There is 2 plus. extremity pitting edema. And in look here, creatinine is higher, hemoglobin is 10.7, creatinine is higher, urine dipstick is negative for protein and the blood, serum creatinine 3 weeks ago 1.1. So if serum creatinine doubles less than 2 weeks, then we can call it type 1 or HRS. But in here, the patient is on diuretic. Even if he is on diuretic, he is not improving. The ascites is not improving. Which of the following is the best next step in diagnosis the cause of patient's AKI? So we can diagnose this patient AKI by urine sodium measurement. Okay, look here. If there is urinary obstruction is present, if urinary obstruction present, yes, appropriate management. No improvement, hepatorenal syndrome suspected. If urinary obstruction present, no, collect urine analysis. Collect urine analysis. If urine analysis show bland urine analysis, then hepatorenal syndrome is suspected. So bland urine analysis one of the thing for hepatorenal syndrome. If abnormal urine analysis or history suggests specific for acute tubular necrosis, acute interstitial nephritis, then go to appropriate treatment. If bland urine analysis, urinary hepatorenal syndrome suspected, then what next test can you do? You should measure urine sodium and give a trial of volume expansion. If improvement, intravascular volume depletion, continue volume expansion if needed. If no, if no improvement, even if you give a trial of volume expansion, volume expander, like albumin, there is hepatorenal syndrome, initiates splanchnic vasoconstrictor, and seek liver transplant, and seek liver transplant. Okay, so if we look at here, evaluation of the AKI, okay, ruling out of urinary obstruction, evaluation of the AKI, ruling out of urinary obstruction and collecting the sample of urine analysis, the patient's normal renal ultrasound exclude normal renal obstruction or normal renal ultrasound exclude obstruction post-renal AKI and a bland urine analysis, that means no protein, no blood. So bland urine analysis, no protein, no blood makes intrinsic AKI unlikely. In contrast to these patients' prerenal AKI that it resolves with volume expansion, patients with cirrhosis can develop severe form of prerenal AKI called hepatorenal syndrome. So hepatorenal syndrome is driven by a neurohumeral cascade. This is the neurohumeral cascade. So if there is portal hypertension, there is splanchnic vasodilation, which will decrease effective arterial blood volume and decrease and chronically very low BP. And as there is decrease effective arterial blood flow. There is decreased renal perfusion, which will increase the RAS activity, RAS causing vasoconstriction, renal vasoconstriction, and sodium retention, renal vasoconstriction, sodium retention, ascites, and overwhelming. Uh, and often it is triggered by the event like infection, like GI bleed, overwhelming renal vasoconstriction, acute and refractory renal failure, death without liver transplant. So, hepatorenal syndrome involves magnetic vasodilation that shunts blood away from the kidneys, which results in severe hyperactivity of the renin, angiotensin, aldosterone system. This leads to extreme sodium reabsorption, which causes ascites to, and that can become diuretic resistance, as in these patients. So, RAS hyperactivity also causes profound renal vasoconstriction that lead to rapidly progressive AKI. So due to the remarkable renal sodium avidity in the HRS, a very low sodium, less than 10 milliequivalent per liter versus 20 milliequivalent per liter is classic prerenal AKI. Is helps in diagnostic clue. A lack of improvement with volume expansion, intravenous albumin helps to confirm the diagnosis since underlying cause is altered splanchnic and renal blood flow. So this is all about hepatorenal syndrome. It's a very high yield topic. Hope you enjoyed.